Hello everyone. Welcome to MedsMaster. In this video let's talk about sulfonamides. We will cover about mechanism of action, ADME of sulfonamides and sulfonamides in systemic and topical use and its adverse reactions. The sulfonamides drugs were the first effective chemotherapeutic antimicrobial agent and they are derived of para-aminobenzene sulfonamide and are congeners of PABA. Most of them are insoluble in water but their sodium salts are readily soluble. The advent of penicillin and other antibiotics diminished the usefulness of the sulfonamides for the prophylaxis and treatment of specific microbial infections. And next will be mechanism of action of sulfonamides. Sulfonamides are competitive inhibitors of dihydroaptate synthase and bacterial enzyme responsible for incorporation of PABA into dihydroxyapatite acid. Cellular and humoral defense mechanism of the host are essential for final eradication of the infection. Toxicity is selective for bacteria because mammalian cells require preformed folic acid. And next let's talk about ADME of sulfonamides. First, absorption of sulfone. Except for sulfonamides especially designed for their local effects in the bowel, this class drug is absorbed rapidly from the GI tract. Approximately 70 to 80% of an oral dose is absorbed and sulfonamide can be found in urine within 30 minutes of ingestion. Peak plasma levels are reached in 2 to 6 hours. The small intestine is the major site of absorption, but some drugs are absorbed from stomach. And next is distribution of sulfonamides. The sulfonamides readily enter pleural, peritoneal, synovial, and ocular and similar body fluids and may reach concentration therein that are 50% to 80% of the simultaneously determined concentration in blood. Because the protein content of body fluids is low, the drug is present in unbound active form. After systemic administration of adequate doses, sulfadiazine and sulfasalazole attain concentration that may be effective in meningitis. Because of emergence of sulfonamide-resistant microorganisms, these drugs are used rarely for the treatment of meningitis. Sulfonamides pass readily through the placenta and reach fetal circulation. The concentration attained in the fetal tissues may cause both antibacterial and toxic effects. And next is metabolism of sulfonamides. Sulfonamides are metabolized in the liver. The major metabolite is the N4-acetylated sulfonamide. Acetylation results in products that have no antibacterial activity but retain the toxic potential of the patent substance. And finally, elimination of sulfonamides. Sulfonamides are eliminated from the body partly as the uncharged drug and partly as metabolic particle. In acid urine, the older sulfonamides are insoluble and crystalline deposits may form. Small amounts are eliminated in feces, bile, milk, and other secretions. And now let's talk about sulfonamides in systemic use. Sulfasalazole, sulfamethoxazole, sulfadiazine can be used in systemic use. Sulfasalazole is rapidly absorbed and excreted sulfonamide and extensively bound to plasma protein. Approximately 30% of sulfasalazole in the blood and now let's talk about sulfonamides in systemic use. Sulfasalazole, sulfamethoxazole, sulfadiazine can be used in systemic use. Sulfasalazole is rapidly absorbed and excreted sulfonamide and extensively bound to plasma protein. Approximately 30% of sulfasalazole in the blood and 30% in urine are in acetylated form. Whereas sulfadiazine is rapidly absorbed from the GI tract and about 55% drugs are bound to plasma protein. Peak concentration are reached within 3 to 6 hours. 15% to 40% of the excreted drug is in the acetylated forms. And sulfasalazole acetyl is tasteless and hence preferred for children in oral dose. Sulfasalazole acetyl in combination with erythromycin ethylsuccinate is used in children with otitis media. Because of its high solubility in the urine as compared with sulfadiazine. Sulfasalazole infrequently produces hematuria or crystalluria. Whereas precaution must be taken to ensure fluid intake adequate to produce a daily urine output of at least 1,200 ml in adults. Sodium bicarbonate can be given to reduce the risk of crystalluria. And next is sulfamethoxyl. Sulfamethoxyl is a congener of sulfoxyl, but its rates of enteric absorption and urinary excretion are slower. It is administered orally and employed for systemic and UTIs. Precautions must be observed to avoid sulfamethoxyl crystalluria because of high percentage of acetylated relatively insoluble form of drug in the urine. The clinical uses of sulfamethoxyl are the same as those for sulfasoxazole. It is marketed only in fixed-dose combinations with trimethoprim. And now sulfonamides in tropical use. Sulfacetamide is the N1-acetyl substituted derivative of sulfanilamide. Its aqueous solubility is about 90 times that of sulfadiazine. Sensitive reactions to sulfacetamides but should not be used in patients with high sensitivity to sulfonamides. A 30% solution of the sodium salt has a pH of 7.4, whereas the solutions of sodium salts of other sulfonamides are highly alkaline. And next is silver sulfadiazine. Silver sulfadiazine is used topically to reduce microbial colonization and the incidence of infections from burns. It should not be used to treat an established deep infection. Adverse reactions, burning, rash, and itching are infrequent. It is considered an agent of choice for the prevention of burn infections. And next is mefenide. The sulfonamides mefenide is applied topically to prevent colonization of burns by a large variety of gram-negative and gram-positive bacteria. It should not be used in the treatment of deep infection. Adverse effects include intense pain at sites of application and allergic reactions. Application of the drug over a large burn surface can lead to appreciable systemic absorption. The drug and its primary metabolite inhibit carbonic anhydrase, and the urine becomes more alkaline. Metabolic acidosis with compensatory tachypnea and hyperventilation may ensue. These effects limit the usefulness of mefenide. And now let's go on with therapeutic uses. First, use of sulfonamide in urinary tract infection. Because of significant percentage of UTIs are caused by sulfonamide-resistant microorganisms. Sulfonamides are no longer a therapy of first choice. Trimethoprim sulfamethoxyl is preferred. Sulfasaxazole may be used effectively for cystitis in areas where prevalence of resistance is not high. The usual dosage is 2 to 4 gram initially, followed by 1 to 2 grams orally 4 times a day for 5 to 10 days. And next is nocardiosis. Trimethoprim sulamethoxyl is most commonly used for infection due to nocardia species. Sulfasoxazole or sulfadiazine are alternative agents. For serious infection, addition of second agent, such as imipenem amikacin or linezolid, is recommended. And now let's see toxoplasmosis. The combination of pyrimethamine and sulfadiazine is the treatment of choice for toxoplasmosis. Pyrimethamine is given as a loading dose 2000 mg followed by 50 to 75 mg orally per day, with sulfadiazine 1 to 1.5 g orally every 6 hours, plus folinic acid. Patients should at least receive at least 2 liters of fluid intake daily to prevent crystalluria. And finally, we will talk about adverse reactions. First, let's discuss hypersensitive reactions due to sulfonamides. Among the skin and mucous membrane manifestations attributed to sensitization to sulfonamide are morbilliform, scarlatinal, urticarial, erysipoid, pemphigoid, purpuric and petechial rashes, as well as erythema nodosum, erythema dermatitis, and photosensitivity. These hypersensitivity reactions occur most often after the first week of therapy but may appear earlier in previously sensitized individuals. And the next adverse reaction is disturbances of the urinary tract. The risk of crystalluria is very low with the more soluble agents with sulfasoxazole. Crystalluria has occurred in dehydrated patients with HIV who were receiving sulfadiazine for toxoplasma encephalitis. Crystalluria can be prevented by maintaining daily urine volume of at least 1,200 ml in adults, or alternatively urine alkalization, because the solubility of sulfoxazole increases greatly with slight elevations of pH. And next, disorders of hematopoietic system. Although rare, acute hemolytic anemia may occur. In some cases, it may be due to a sensitization phenomenon. In other instances, the hemolysis is related to an erythrocytic deficiency of G6PD activity. And finally, miscellaneous reactions. Anarrhachia, nausea and vomiting occur in 1 to 2% of persons receiving sulfonamides. Focal or diffuse necrosis of the liver owing to direct drug toxicity or sensitization occurs in less than 0.1% patients. The administration of sulfonamides to newborn infants, especially if premature, may lead to the displacement of bilirubin from plasma albumin, potentially causing an encephalopathy called kernicterus. Sulfonamides should not be given to pregnant women near term because these drugs cross the placenta and secreted milk. Hope you got load of information. Please support us by subscribing to our channel.